So this session will be recorded and will be made available on our website tomorrow. You can go directly to our website probably in the afternoon at cwpv.org/blog, and you will see the recording of this educational session presented by Jennifer Brown. A couple of notes, because we do have so many people, over 75 people registered today, we ask that you please use the chat function in order to ask any questions that you have. And I will let Jennifer know of those questions. We have specific spots and natural spots after certain topics where we will pause and I will ask the question. I may chat with you if I don't understand your question so that I can understand that before Jennifer is asked the question. But we do have a good amount of time today, but we have a lot of information to cover. So I would ask that everyone remain muted so that other ancillary things happening in the background don't take over the screen for everyone else. So please keep yourself muted and use the chat function in order to ask your questions. I will say that in the new year, we hope to have a few more of these series. We're going to provide another one on in-home healthcare. That will likely be possible, as well as Rehab 101, what you need to know. And so if you have other thoughts or ideas about educational topics of interest that would be important to you, please give us an email at info@cwpv.org, and we'll take that into consideration in these educational sessions, which seem to be resonating with folks. So I'm glad that's the case. As I mentioned last time, it's my pleasure to introduce Jennifer Brown. And she will tell you a little bit more about her, but I'm really pleased because Jennifer and I have known each other for many years. She was one of the first people that I ever met when I was placing my aunt into a memory care facility, and I really relied on Jennifer's guidance. So she's now retired. She's not representing any one organization or entity, which is, I think, really important for her objectivity. So thank you, Jennifer, for being here, and I'll turn it over to you to tell us a little bit more and get started.
Thank you very much, Frank, and it's a pleasure to be here again this afternoon. Thank you all for turning out. It's quite a nice feeling to see so many folks want to be part of the webinar, and I know many of you are returning from last week's webinar, and some of you, this may be the first time that you're on the call. You weren't able to attend the first session. I have a 50-year background in the healthcare industry. The last 22 years were exclusively in older adult services. I worked directly in residential care for over 15 years, and I have a background in psychology, bachelor's and master's degree. I am not a licensed social worker or a nurse. I really come more from the business side of the healthcare field rather than being a clinician. That said, I'm going to share my screen. I do encourage you to put questions in the chat. We will do our best to answer as many questions as possible. And I will try not to pontificate too much and keep to the point. So thank you again, and I'm gonna share my screen now and we'll get started. So as Frank indicated, we're going to focus on specialized residential care. We're going to discuss assisted living, memory care, and long-term nursing care, and try to give you an overview of each of these specific care environments and what's involved in terms of the services, admission criteria, options, etc. I want to again acknowledge and thank Cleveland and Woodley Park Village and Frank for hosting this program. This is the contact information for the village. one thing I want to point out is the village has a very, very good resource on its website. So some of the information I might be touching on today, some more information about some of the communities, et cetera, are on the Cleveland and Woodley Park website, and you can check that out for further information. As Frank said, I am retired. I did work for a number of residential communities. I worked for a number of other companies that provided services within the medical field, the healthcare field, and specifically for older adults. And I just want to say I am not advocating, promoting, recommending, endorsing any community. I'm trying to be as objective as possible. I'm going to list a number of communities to give you examples of the types of services and the types of communities that are in the DMV, but I'm not singling them out to try and push or advocate or, endorse any of those specific communities. Okay, so assisted living residential communities, they're what I refer to as the market rate communities, those that are higher, kind of the high-end options. There are some moderate income communities, and they're in assisted living. It's limited, but there are Medicaid facilities that take Medicaid funding to cover assisted living care. We're going to talk about the specialized memory care programs, and we will wind up looking at long-term nursing home care. So what is assisted living? Assisted living is licensed by the state. So DC, Maryland, and Virginia each have their own licensing bodies. They go through the Department of Health in the District of Columbia. The criteria for the licenses and the regulations are similar, but not identical. Assisted living is not covered by Medicare. There are a few parts of services you receive or could receive being in assisted living that may be covered under your Medicare benefits. But by and large, you need to not assume that Medicare is going to be much help in assisted living. It's private pay. If you have long-term care insurance, you may have benefits on your long-term care insurance policy that would help cover the costs of assisted living. And as I noted before, there are in the DMV some communities which accept Medicaid as a payer for assisted living services. Assisted living provides personal care and support with activities of daily living. And there's a lot of acronyms in the healthcare field. And, every business, every profession has its jargon, and we've got more than our share. So you'll hear the term ADLs, activities of daily living. You'll also hear a reference term of levels of care. The activities in daily living and the levels of care are related to each other. Assisted living has some very specific admission criteria and protocols. Again, they vary slightly between Maryland, DC, and Virginia, but they're fundamentally the same. But it is a more complicated process to be admitted and to move into an assisted living environment than to go into independent housing. Assisted living communities will provide, in conjunction with hospice providers or other support services, end-of-life care. So you can receive end-of-life support in assisted living. Just a sidebar, hospice services, and we're not discussing hospice today, is available to you in your private home, is available to you in an assisted living community, is available to you in an independent housing unit, is available to you in a nursing home. Hospice is a service, it's not a space or a place, and you can receive that support under your Medicare benefits in any living environment. Assisted living is very expensive, period. There is often an entry fee, a one-time charge. There is a monthly rent. The monthly rent is going to vary by the size of your living unit. And then there'll be level of cost fees or fees that are related to helping you with your activities of daily living. And there may be some ancillary charges in addition to all of these. So when you're looking at assisted living or memory care, you need to have a full picture of what your monthly costs will be, and it's more than the room and board. So activities of daily living, what does that mean? That means meals, dining services, transportation, housekeeping, laundry, maintenance. Those are kind of the basic ADLs. And then they get more advanced and more personalized: bathing and dressing assistance, showering assistance, grooming, assistance with ambulation and transfers. And those are the more advanced activities of daily living, which an assisted living community will help you with and provide support for. Medication management and administration. Again, it's going to vary from location or provider or organization. Medication and management administration may be a standalone service, or it may be part of a level of care. And I know it's going to get confusing, and unfortunately, there's no one answer to this. It's going to be specific to each provider of service, how they structure their fees, how they charge for their fees. Probably the most advanced care in assisted living is incontinence care, toileting, and feeding. Again, it's going to vary community to community, how much personal one-on-one care someone can receive and be in an assisted living environment. So these levels of care, and you'll also hear the reference to level of acuity. Acuity means intensity. Higher levels of care means a higher level of acuity. And you can have levels 1, 2, and 3, and 4. Not all communities have 4 levels. Some may have 1, 2, or 3. Sometimes they may be restricted in their license to a lower level of care, like levels 1 and 2, and not levels 3 or 4. Again, this is going to be specific to the individual community. As I've said before, medication management administration may be a separate service or may be part of the level of care. Medication management means the facility is going to have a list of all your prescribed medications and your over-the-counter medications. They're going to have orders, physician orders, like you have orders for your prescription medications that you get from CVS or Rite Aid or Walgreens. They're going to order those medications from a pharmacy. Those medications are going to be stocked in the assisted living nursing station, and they're going to administer it to you. They're going to provide you your medication based on your physician orders, your doses level, how many medications you get per day, what time of day you receive them. That is part of assisted living service. It's a very basic assisted living service. The other thing that I would point out, and I said you can have ancillary costs beyond the room and board, beyond the level of care, beyond the medication management administration, is personal consumable supplies. So if you need incontinence products, the assisted living community will provide you those incontinent products, and they'll charge you for those supplies based on your personal consumption of those supplies. Other costs in assisted living would be the barbershop and beauty salon. They may have specific fees if you're going on certain outings or trips. There may be specific fees regarding personal transportation. Again, that's going to be community by community. Almost every community has a beauty salon and barbershop. Almost every community has a fitness center or some kind of gym. Most communities provide therapy services, PTOT and speech. Generally, PTOT and speech services are covered under your Medicare. So that'd be one item of service you would receive in an assisted living environment that would be covered under your Medicare benefits and not be an out-of-pocket expense. Admission criteria and protocols. Again, these is defined by each state, but generally it's going to require a written report from your primary care physician. And in that written report, the physician is going to be asked what is their recommendation. And when I say it's time sensitive, the written report from your physician, again, these regs will vary slightly from jurisdiction to jurisdiction. That written report has to be dated and signed by your physician within 30 days of your admission into the community. So you cannot take a visit to your doctor 6 months ago where he wrote up a report for you and he sends it in and it's 6 months out of date. Now your physician may, if they know you well, sign a report, fill out a report and date it. Even though they may have seen you 3 months ago, they will date it the date that they fill out the paperwork. And that's fine. That's perfectly fine for your admission. You're going to need a TB test. The TB test has to be current within 30 days. Based on the community, you will need a COVID vaccination and or a COVID test. And I'm not about to know what communities require in terms of boosters, when your last COVID shot was, when you would have to have a COVID test. But I assure you there would be some COVID policy for admission into a residential care environment. You're going to have to sign a residential contract or an agreement, either you as the person or you as representing another individual. If you're a married couple, signing a contract for your spouse is generally pretty straightforward. If you're not a married couple and you're an adult child or you're somehow other relationship to the individual moving in, you should have a power of attorney in order to go and enter into a contractual relationship representing another person. You're going to have an interview by the assisted living community. Generally, that would be by a registered nurse. Again, I'm not saying that's an absolute. And it may include more than the registered nurse. There may be a social worker. There may be some other person, professional, participating in the interview and assessment. And based on that interview and assessment, based on the report from your primary care physician, that nurse is then going to determine your level of care, and that level of care is going to determine what you pay for services in that assisted living environment. They're going to focus on cognitive ability and cognitive impairment, memory. They're going to want to look at ambulation and mobility. And I want to be clear, and I'm being very blunt, assisted living has many folks who have normal aging memory loss, and maybe a little more than average or normal cognitive decline. You can be in assisted living. You can thrive in assisted living. You can be very comfortable in assisted living and not require memory care and still have some memory loss. that is a very vague statement in terms of where you draw the line. I can try to be more specific, but it really is on an individual by individual basis. But because you need medication and management administration, because you can't remember to take your meds on time, because you have other memory issues that you're aware of, does not mean that you have to be in a memory care environment to be safe and happy and have a good quality of life. If you are going into a community under a Medicaid program, obtaining a Medicaid waiver, that is in addition to all of this. And I am not an expert in Medicaid or Medicaid waiver, but if you're eligible and you meet the criteria, you're going to go through a Medicaid waiver procedure protocol so that the community that's providing you care will be reimbursed by Maryland, Virginia, or DC Medicaid. Okay, Frank, let's have we some questions coming up yet?
Yes, we have one. Do DC, Maryland, or Virginia participate in the PACE program?
So yes, there are PACE programs in DC and in Virginia. I also assume they're in Maryland. There's a PACE program, at least one or two in the district. There's one in Alexandria, Virginia.
Can you define for folks what the PACE program is, Jennifer?
I'm on thin ice here.
Okay.
The program is a managed Medicaid product which puts together your Medicare benefits and your Medicaid benefits and provides support and services to keep someone home and not living in assisted living, memory care, or a nursing home. So it is a community-based service. It combines home care. It combines adult day services, and it bundles your primary care physician, your specialists into a consolidated care package that you receive as a member. So think of it as a managed Medicare, Medicaid insurance product in which it's focused on comprehensive support to help someone remain safe at home and not go into a residential program.
Okay, great. We don't have any other questions, so I think we can go on now. And
Okay.
I encourage folks to please put your questions in the chat, and I will be managing those, and we'll be giving them to Jennifer at various points.
Okay. Getting to know the key players is very important. And the titles and the different categories will vary from community to community. And if you're considering moving in, or you're considering moving in with a loved one, or you're helping someone else move in, you want to talk to more than the sales and marketing person. As I said, the individual who's going to be a resident is going to be interviewed by a nurse and maybe a social worker. Before you make your final decision, before you sign the contract, before you write the check, I encourage you to meet the senior director or administrator of that community. Many residential communities may have a medical director and who will take you as a primary care patient. But I need to emphasize, in assisted living or in memory care, you may maintain your own primary care physician, your own specialist, your own cardiologist, your own oncologist, blah, blah, blah. If you go into long-term nursing home care, that's a different scenario. Life enrichment is the activities person. So if the activities, the events, the social life, the spiritual life, the outings, if that's important to you, interviewing, talking to the life enrichment director or manager would be a key decision point. Social workers are not present in all assisted living or memory care programs. They are not required by regulation. The operator may have a social worker on staff. If you are going into a nursing home, social workers are required by regulation. If you are going into assisted living in a life planning, a continuing care retirement community, a CCRC, they often will have social workers as part of their program. But by regulation, if you were considering a standalone assisted living community or a standalone memory care community, they are not required to have a licensed social worker as part of the staff. In some of these communities, they may have a program director in addition to administrator or an executive director. And the program director is a combination of folks. They might be a social worker, they may not be, but they would be someone who would do programming support, social work support, care coordination, and they can be a very valuable asset to residents and to the community. The key people in any of these organizations are certified nursing assistants. Those are the folks that are the hands-on. Those are the folks that are going to provide the most personal care. Those are the folks that you're going to see every day. Those are the folks that you're going to have a personal relationship with. And they're going to really be the individuals that are going to be critical to the quality of your care and your safety and well-being. There's one other category that I did not put on this slide. Is called a med tech. And a med tech, again, these folks are licensed by the jurisdiction in which they work, Maryland, Virginia, and DC. Med techs in certain situations can provide medical administration, medicine administration and management. They are not licensed nurses, but they can provide medication management and administration. Okay. Any more questions yet, Frank?
Not yet.
Okay. So in assisted living, as I said, you can be in an amenity-rich market rate community. You can go into assisted living in a large continuing care retirement community or CCRC. There are a lot of small residential group homes, primarily in Virginia and Maryland, much less so in the District of Columbia, which are licensed assisted living communities, but they are small, usually 8-person residential care homes, and they typically reside in residential communities, in suburban residential areas, not in commercial areas. And then you have the last group, the affordable subsidized Medicaid waiver communities. And I'm repeating myself, they are not as plentiful as these other options. In a market rate assisted living community or an assisted living community, which is part of a continuing care retirement community, you're going to have a lot of options, a lot of different floor plans. You're going to have small apartments, big apartments, maybe 2-bedroom apartments, a 1-bedroom with a den. There's going to be a lot of activities and amenities, lots of clubs and outings and entertainment. They're going to have fitness centers. They're going to have beauty salons and barbershops. They might have a movie theater. They might have a bar. So you're going to have a broader palette of services and amenities. And they're going to have advanced personal care. So they're going to provide, through their own personnel, high levels of personal support and care. They typically will have therapy services available on site. The therapists are generally not employees of the residential communities. They can be, but these are going to be licensed physical therapists, occupational therapists, speech pathologists who provide personal therapy services to you. And again, that's generally covered under your Medicare insurance. And most of these communities will have a rehab gym or fitness center where you can receive therapy services, particularly OT and PT, with all the bells and whistles of the rehab equipment. The small group homes, again, are small. They're 8 persons. They are generally lower cost than the market rate assisted living communities. They will offer semi-private rooms so you can reduce your cost by having a roommate. They do have various levels of care, but they may not have the most advanced personal care services available. And because of their structure, because they are smaller, they may have a limited amenities and activities because there's only 8 people, rather than when you're in an environment where there's 80 people.
Jennifer, if I could ask a quick question. I know of these group homes in Maryland and Virginia, but are they available in DC? Does DC allow these types of homes?
It's not a question of allowing them. It's getting they are private homes that's retrofitted for a maximum of 8 people, and sit in residential areas. They're not excluded in the District of Columbia, but to be perfectly blunt, it's more difficult to find the right property and to have the right floor plan for these things to work. You generally need a ranch style home versus a multi-tier, 2 or 3 story home. You generally need a large footprint. You generally want some outdoor space, and that's a lot harder to come by in DC, and it's a lot more expensive.
Yeah. Do you know of any in DC?
I'd have to get back to you on that. There were a few, but I have to pass right now. I'd have to come back with you for that one.
Great, thank you.
Okay. And then as the last group under this assisted living category are the Medicaid waiver communities. Okay. So in the life planning communities, and there are a lot of them throughout the DMV, you can enter a life care community as an assisted living resident or a memory care resident without going through the life plan contract and investment. Now, it's based on availability. So if you were to contact Rock Creek, or you were to go to Goodwin Living, or you were going to contact Riderwood, if they had availability in memory care or assisted living, and they did not have an independent resident who is waiting for that living unit, you could be considered a candidate to move into Ingleside Rock Creek Assisted Living. You're going to pay an entry fee. It is not going to be a big buy-in like buying a life care contract. You are not going to have a life care contract, but you will have, once you become a resident of Ingleside or resident of Goodwin, you would have the options, if you ever needed to live in memory care or needed to have access to the skilled nursing facility within Ingleside or Goodwin or Erickson, you're part of the community. But it's based on availability, and it also means that there aren't independent residents who are in the queue who are going to be considered priority over someone coming in from the outside. Okay.
And just a reminder to folks, I see folks some writing them down or taking pictures. These slides are going to be available on our website tomorrow. So you'll have full access to this information tomorrow on our website, which will be at the end of the slide, and I'll remind you of that address later.
And there are more continuing care retirement communities within the DMV than are on this slide. The Knollwood, Vincent Hall, Falcons Landing, the Fairfax, those are all military communities that have specific admission criteria in regards to military service and or high GSA rating upon retirement. So they have a separate culture and kind of criteria than the other continuing care retirement communities, which are not do not have a military base to them. Okay. So these are market rate communities. Again, there are hundreds of them throughout Virginia, Maryland, and DC. Grand Oaks, many of you are familiar with Grand Oaks. That is part of Sibley Memorial. It's part of Johns Hopkins Medicine. Chevy Chase House, Thomas Circle, Forest Hills. There are many Sunrise Senior Living communities in DC, Maryland, and Virginia. So again, these are just examples. These are group homes. Again, you see them being in Maryland and Virginia more than DC, and I'll get an answer for Frank. You will find that there are some small group homes which are dedicated to dementia care, but in general, they are not dedicated dementia care environments. They are assisted living communities, but not specialized in dementia care.
Jennifer, if I could just ask, if you could give an approximate range. I know in DC for some of these.
All right, so you're looking at a starting apartment rate of about $6,000. You might be able to get a studio under $6,000. Then you're going to go somewhere to the $7,000 or $8,000 a month rent. Now that rent is going to have a lot of amenities in it: TV, telephone, transportation, housekeeping, laundry, meals. So it's not just renting an apartment. You get a lot of other value for your $7,000. But the level of care is going to be in addition to that rent. And the the beauty salon, the barber shop are not going to be included in the monthly room and board. But in the amenity-rich communities, that monthly rent will cover a lot of waterfront in terms of what you receive. But less than 6,000 is less than 7,000 can be hard to find. And then if you really want them larger apartments, it's going to be more.
And just a few other questions, if I could ask, Jennifer. One is that fee is based upon the level of care that one qualifies for at the beginning, and that can change, correct? So that if one's needs become greater, then the fees also go up? I think I'm pretty sure.
Go in both directions. If you're recovering from hospitalization or surgery or something, you may need a higher level of care for the first 30 or 60, 90 days. And if you're able to be more self-sufficient, your level of care can go down. As you age in place and your level of acuity, the intensity of services you need for your safety and well-being go up, then your level of care will go up. Based on the community, there'll be some policy or procedure around a review of your level of care. It could be every 6 months, it could be once a year, or, and your contract's going to say this, or if there's some precipitating event which causes the level of care to be reviewed more frequently than every 6 months or whatever the standard protocol is. The other thing you can consider, and this will drive up your costs further, is you could bring in private duty help, and that relationship is between you and the private duty caregiver, and you may be able to reduce your level of care, what you're paying the community to do, so you're not duplicating services. I made that sound real simple. It's not. It's complicated. It's a negotiation between the residential community and yourself, your loved ones, and what you would do in terms of bringing in private support to give you services that you're paying for independently of the residential community.
Great.
Okay.
And Jennifer, if I could just ask, if one has limited assets and then runs out of those assets and needs to go to, what happens then? Do they go to a different facility? Does that existing facility that they're in then accept the Medicaid rate? How does that work? If you could speak to that a little bit.
Okay. This really is important if you're signing a contract, if you're entering into assisted living and memory care. You need to really understand the terms and conditions, failure to pay, the rights of the community, your rights as a resident. In general, many of the private pay communities, when you deplete your assets, have limited options for you to remain there. If you're in a CCRC, again, you need to really address this up front. And you've been in assisted living in that CCRC for a period of time, if you've been in memory care for a period of time, and you're able to transition in that continuing care retirement community's nursing home, and Medicaid will pay for you to remain in that nursing home, that may be an option for you. I'm not making that as a guaranteed statement. If you're in a standalone assisted living community and you've depleted your assets, you may be looking at a relocation into a Medicaid licensed living environment.
Oh,
If everyone could please just mute, we have some background noise there.
Most of the market rate assisted living communities, I'm sorry for the general language, are not accepting Medicaid waiver as payment for someone. They're not set up that way. So you really need to drill down on the community. You really need to understand what the contract says, as well as what the marketing person is saying to you in regards to what happens when you run out of money. and what
Yeah.
their responsibility is and what your responsibility is.
Just two other quick questions, Jennifer. Is the RN or whoever does the initial assessment interview an employee or someone contracted by the
In
center?
general, they are employees of the organization.
Okay. And is there a national organization that rates or certifies these facilities?
There are several national trade associations, but they're trade associations. The ratings and the criteria and the licensing is state-based. So it would be the state of Maryland, it would be the District of Columbia, it would be the state of Virginia. Now, you could, I'm being a little guarded here because they're going to vary. You go to dc.gov, Department of Health. You can search to see what you can find about the licensed assisted living communities within the District of Columbia and what information they have posted publicly about their annual surveys and audits. Similar in Virginia, similar in Maryland. These communities are highly licensed, they're highly regulated, they're subject to periodic unannounced audits by the licensing body, the Department of Health for the District of Columbia, et cetera, but they are not national, those are state.
Okay, and then just another quick question. If you have a long-term care insurance policy that will cover certain nursing services, can this be negotiated to reduce assisted living costs? And how does one go about finding an individual to help someone do the negotiation and selecting and signing a contract for residential care?
Okay. Most communities will say that they will assist you in filing your long-term care insurance claims. They will help with the documentation to get you qualified to meet the criteria as a beneficiary of the long-term care policy to be reimbursed. But they are generally not going to collect payment directly from the long-term care insurance company. So what they will say is, your cost to be here per month is $8,000, including room and board and level of care. You may be reimbursed from your long-term care insurance policy. I'm picking numbers out of the air, $5,000 a month. So what that means is you're paying XYZ assisted living, $8,000 a month. You're getting a check from your insurance company, you are, for $5,000 a month, and you're paying that differential, that $3,000, to the provider. And I generally do not think they will adjust their fee schedules to what your long-term care insurance company is providing as payment as a benefit under your policy. You can get assistance in two ways. You could look at an aging life care manager or geriatric care manager who is a social worker, not a lawyer, and they can help with the whole process of finding a community, reviewing the contract, helping with the level of care determination, et cetera, et cetera. You can hire an elder law attorney, a lawyer, who has a specialty in elder law, or sometimes you can work just as well with an estate planning or trust attorney, but you want to make sure that the estate planning or trust attorney is knowledgeable about assisted living and memory care contracts. And you might want them to review the contract, give you advice on the contract. It's very difficult to change the boilerplate of a contract from a large corporation or even a small corporation. But what an elder law attorney will do, or a good aging life care manager will do, was clearly explain to you what your risks are, what your benefits are, what the terms or conditions are, so you understand what you're getting into. I've worked with elder law attorneys. They are excellent assets. They are valuable to older adults. And they'll come and they may try and come in and say, well, we're going to want to delete this paragraph, or we're going to add this paragraph, or we want to take this sentence out. I'm not trying to be smart about it. That is a very tough road to hoe.
Great, thank you, Jennifer. And we'll present some resources at the very end so folks know how to access some of these either elder law attorneys or care managers. So we can go ahead and proceed.
Okay. So these are subsidized and or Medicaid waiver assisted living communities. There's more than these in Virginia and in Maryland. There's not a lot more in the District of Columbia. The availability can be difficult in terms of getting an open unit room. And they are set up, so if you qualify for DC Medicaid, Virginia Medicaid, Maryland Medicaid, that you meet the criteria under the state Medicaid regulations, you can be admitted into an assisted living community where Medicaid will be your payer source for you to stay there. And you can stay there indefinitely under your Medicaid benefits. However, if your level of acuity really exceeds the capacity of the assisted living environment, you still could be confronted with the need, requirement, demand that you move into a nursing home. If your care needs exceed the staffing capacities and the abilities of the assisted living community under your Medicaid benefits, you may or may not have to consider a nursing home placement. The other thing I want to say about, I need to focus on the DC properties versus the Virginia and Maryland properties. The Lisner home is primarily a nursing home. It has a dedicated assisted living memory care program under Medicaid. The other, Livingston Place, Abrams, and Kenilworth Park, are not memory care programs. So they are assisted living. They don't assume that you have perfect cognitive ability. But if your cognitive health declines, they have limited capacity to care for you and maintain your safety and well-being in their living environments. To be really specific, if you're highly ambulatory and you are experiencing cognitive loss and you're a flight or wander risk, or you could elope, sorry for this language, these communities are not set up as high security residential memory care programs. So they would not be able to give you the level of care that you would need indefinitely. Okay?
And just to be clear, we're giving some examples here to everybody, and Jennifer's pointing out some different services that each of these provide. But we're not here today to rate any of these in terms of the quality of the care that they provide, or give information, feedback on any of them. We encourage you to talk to other village members. If you have a village that has a dedicated village talk, that's something that you could, a chat function, you could use that in order to seek other input. But today we're not going to be discussing the feedback, giving a Yelp review, if you will, to any of these facilities.
Just because someone has a limited capacity in terms of the level of care or level of acuity doesn't mean it's not a good provider. Different environments have different structures and staffing and support to meet the needs of their residents, and they're not all the same. That doesn't make them good or bad. Okay? Okay. All right. Memory care assisted living is not standard assisted living. It is a specialized living environment. Again, these are they are licensed as assisted living, but the memory care programs are unique. They have a secure, restricted access to the residents. Getting in and out is supposed to be difficult. And I know that sounds harsh, but the safety and well-being of an individual who has cognitive impairment is paramount. And you can't have a living environment where someone innocently walks out the door and is on Connecticut Avenue or Georgia Avenue or Wisconsin Avenue, and their safety and well-being is in danger, because they shouldn't be out on the street without assistance. They have hired a staff to resident ratios. I can't give you a number, but one of the things that you would ask and talk about is exactly that. What is the resident to staff ratio in terms of the caregivers? The memory care programs, unlike the assisted living programs, may bundle their rent and level of care into one number. So they may put it all together and say the monthly fee is XYZ. It includes the personal care, the bathing, the dressing, feeding assistance. It may include all of that, except the consumable supplies. The consumable supplies are always going to be an additional charge. But instead of having various levels of care, it may be a flat fee, depending on the community. The programming and activities and entertainment and exercise is all geared towards the resident population. So you have social programs, entertainment programs, exercise programs that are really geared towards the safety and well-being and the quality of life of someone with cognitive loss. These communities typically have secure outdoor space. So you're able to be outdoors. You're able to be in the fresh air in the courtyard and have barbecues or whatever, but the exterior space is secure so that an individual is not going to inadvertently exit and be in an unsafe situation out on the street. There are very specialized providers for this, as well as assisted living communities, which will have an assisted living component part of their campus, and then we'll have a separate, secure, dedicated memory care component of their campus. Again, that's going to vary. And I apologize for repeating this one. Under Medicaid, or the subsidized senior assisted living programs, memory care is a lot harder to come by. As I said earlier, you can move into memory care in a continuing care retirement community. They have highly specialized memory care programs. Again, the availability is going to be the key. Do they have space for you when it's not promised, or there's not a resident in their other living areas that need that memory care apartment? And again, if you're in the memory care unit and you're part of a continuing care retirement community and you need eventual nursing care, that may be available to you. Whether that nursing care would be on a private pay basis, or that nursing care may be covered under Medicaid as a Medicaid beneficiary in a nursing home environment. Some of these communities, Grand Oaks, Forest Hills, Sunrise, Kensington, Brightview, are going to have separate memory care programs. Sometimes they're in the same building. Sometimes they're separate buildings. It's going to vary community to community. These are specialized dementia care companies. So Ardencourt, Artis, Silverado, these are standalone dementia care communities. So they're very specialized. They vary in cost. They can be very expensive. I don't know a lot about Avalon House in Virginia, but Avalon House in Virginia is a series of small living units that are structured for dementia care. I'm just not familiar with them. That's not good or bad. I just don't know exactly how they operate, but they, unlike most of the small group homes, Avalon House is kind of dedicated staffing-wise, structure-wise to dementia care in the group home model. The last two on the bottom that have the double asterisks are nursing homes. They're not assisted living. And I want to be careful with my language here. These two are for the most challenging folks that are experience difficulties with dementia. So they are geared for the most difficult situations in regards to behavior. And the staffing, the structure, the supervision to help folks remain safe but they are the most challenging in terms of behavioral problems. Okay. Any more questions, Frank?
One going back to assisted living, if you were to move somebody from out of state into DC, for example, and then how long would they need to be a resident before then they could qualify for a Medicaid assistance in assisted living?
So the challenge is, if you wanted to be admitted under Medicaid in the District of Columbia, you have to qualify for Medicaid in the District of Columbia before you move into an assisted living community. Coming from out of state, and you really have to speak to the director of that community. You could be a private pay resident temporarily until you became a DC resident. The residency requirements, and I believe in Maryland and in DC are pretty liberal. So you don't have to be living there for an extended period of time before you're a DC resident. I don't know the exact length of time, but it's not like you have to live years in the district to be eligible for DC Medicaid. It's months, but I don't know how many months.
Okay, great, thanks. Just a little more than 20 minutes to go. We can go forward and then we'll take questions at the end.
Okay. Long-term care nursing facilities are licensed under the Centers for Medicare and Medicaid, CMS. So they are federally licensed. They are subject to annual audits and surveys. The results of the audits and surveys are posted online, medicare.gov. Search nursing home, and you will find the most recent survey results, and you will find the historic record of a nursing home survey results. So when you're looking at a nursing home, there is data online. It is from federal surveys and audits. It is required annually, and you can find historic data. So I would encourage you, if you're looking at ABC nursing home, don't look simply at the most recent survey results. Look for several years of survey results. Any nursing home, and I've worked in many, can have a good survey result or a bad survey result, and it can be a little bit of the luck of the draw. So a 5-star rating may not mean that it's a perfect nursing home, and a 3 or a 4-star rating may not be it's a terrible nursing home. So that's why you need to look at it over time, multiple years, to see what the track record is in terms of the rating. They're going to rate staffing levels. They're going to rate information in regards to quality of care. They come in, they audit medical records. They observe care being provided. This happens in assisted living as well. I'm not saying it doesn't, but it is a different format. It's a different set of criteria. And again, it's federal versus state auditors. You have standalone nursing homes, and you have nursing homes which are part of a continuing care retirement community. You have dedicated nursing home providers, which can be regional or national operators. And then you have life planning communities or continuing care retirement communities where a nursing home is a part of that campus and a part of that organization. You're gonna have private and semi-private rooms. You're not gonna have an apartment. You may be sharing bathroom facilities. Even if you have a private room, you may or may not have a private commode and toilet and sink in your room. You're most likely not going to have a shower in your room. You're going to be sharing shower facilities. They're private showers, services, private rooms, but they're not going to be in your living space. They're going to be separate. This is the highest level of acuity, the highest level of staffing, the highest level of nursing and supervision and support. They are going to be required to have a medical director, an MD. In a nursing home, you are going to be under the supervision of the medical director. You're not under the supervision of your primary care physician. So the medical director is going to sign off on your prescription medications and is going to be your primary care physician. You can maintain your specialist, your cardiologist, your oncologist, any of your neurologists, any of your specialty physicians. You would still be able to maintain a relationship with, and their orders, their information, their direction is part of your medical care in a nursing home. The programming, the activities, the entertainment is going to align with that resident population. Now, the key to memory care in a long-term care facility, you're going to have many individuals who are residents of long-term care that have significant cognitive impairment. But they are generally going to be non-ambulatory or have minimal ability to ambulate. So if you have significant cognitive impairment and you need a wheelchair, you can reside and get good care and support, quality of life in a nursing home. If you're highly ambulatory and you may have significant cognitive loss, most nursing homes don't work because they're not high security environments. And if you're highly ambulatory, even though your cognitive ability is significantly compromised and you're wandering around the nursing home, that's a problem. So a nursing home Medicaid bed for someone with significant cognitive loss and still has significant ability to ambulate is going to limit where you can be safe and secure. It's a fact that makes it very complicated for folks that need that level of care and support and need Medicaid to be the payer source. Okay. More questions, Frank?
We're good for right now. So if folks have other questions, you can put them in the chat, but let's go forward since we have limited time.
In DC, there are 16 Medicaid and Medicare licensed long-term care facilities. They're mostly standalone. Some of them are part of a continuing care retirement community, but most of them are not. They're all over the district. There are nursing homes all over Montgomery County, Prince George's County, Alexandria, Arlington, Fairfax, et cetera, et cetera. A lot of them are national and regional operators. There's a lot of consolidation in the nursing home space. There will be more consolidation in the nursing home space. There'll be consolidation in the assisted living space. There'll be consolidation in the memory care space. Many of these providers are for-profit, either publicly traded or privately held. So they're subject to all of the stresses and pressures of the corporate world. Some of them are owned and operated by non-for-profits. Some of them are owned and operated by faith-based communities. That doesn't mean that they are free from the pressures of operating a business. They're not. There are a lot of them. They range in size and structure. Some of them are huge. Some of them are as big as 500 units. Some of them are 200 or 300 units. Some of them are smaller. But they are generally all Medicaid licensed. So they're able to provide lifetime care for the remainder of one's life under Medicaid benefits within a nursing home environment. Okay.
And Jennifer, could you speak to how one could evaluate the financial stability of a for-profit organization that is the owner or operator of one of these facilities?
Well, if it's publicly traded, There's a lot of information that's required to be in the public space. You could, in evaluating or looking at a particular operator, you can ask for the annual report. You can ask to get a printed copy. It may be online. If it's a for-profit that's privately held, that's more challenging to know what the financial profile is. Dun & Bradstreet, you could get a Dun & Bradstreet report. I am not an expert in finance. You want to look at the turnover in the management. You want to look at the stability of the executive director or the administrator. You want to look at the stability of the senior nursing person. You want to look at the stability and the tenure of the other management folk within the organization, a dining service and food service director, life enrichment director, housekeeping and maintenance director. You want to get a sense for the tenure of the personnel, how long they've been at that location, how long they've been in the industry. You want to talk to these people. But you need to do digging on the financial stability of a for-profit company, particularly if it's in private hands. It's owned by a hedge fund or it's owned by other financial entity like a Carlyle Group or a Blackstone. And I'm, again, not throwing any shade on any of these folks. I worked for Carlyle for a period of time. So it is a little bit more difficult if it's a private equity situation versus a publicly traded situation.
Great, thank you, Jennifer.
All right, I touched on the memory care assisted living versus the long-term care facilities. The memory care assisted living are highly structured, secure environments. They accommodate memory care folks with ambulation, very specialized programming. You have the potential in a memory care assisted living for peer-to-peer resident engagement. And I think that's important in the quality of life for your loved one or yourself. Justice Sandra Day O'Connor was very public when she retired from the bench of the Supreme Court to take care of her husband, who I believe had an Alzheimer's diagnosis. I believe this is all in the public record. And she retired from the bench to take care of her husband, and she took care of her husband at home for a period of time. And with all the resources and all the access that the Supreme Court's justice would have, she eventually felt it was required for her and her husband for him to live in a residential memory care program, which I believe was a good decision for Justice O'Connor and for her husband. She has publicly talked and disclosed about the fact that he developed a relationship with a woman in the memory care program. And she would go and visit her husband, and her husband didn't know who she was, which is very hard, very emotionally difficult, very heartbreaking. But he's holding hands with another woman. And I worked in memory care. I've been in memory care. This is a very difficult scenario. But the potential for the residents to bond with each other, it doesn't have to be romantic. This could have nothing to do with romance. But to be in a peer-to-peer support environment can be good for the quality of life of the folks that are there. And like I said, I'm repeating myself, this is a very expensive operation.
Great, and just as a reminder, we just have about 10 minutes left, Jennifer.
And the nursing homes, again, they're generally not structured to provide the kind of memory care support that you would have in a specialized care environment. Okay. All right, who can help? Care managers can help. Licensed social workers. Again, these are paid professionals, they're consultants. You can give them a very, very narrow scope of work. They can assist you. Their scope of work can change as you work with them. They're generally very flexible, but they can be very helpful. But these are paid consultants. There are consultants, advisors that are paid for by the residential communities. So their services to you, and this will be part of how they market themselves, is it's no cost service to you, which is correct. But they are being compensated by the residential community for having a move-in or a new resident move in. So they're receiving a commission by the operator for having a new person come live with that community. Some of these are in person, so you actually are interfacing with a real live person who's assisting you, holding your hand. And others are internet-based, so you're basically doing it all via the phone or Zoom or some other video platform. But these folks are not going to walk into an assisted living community with you. They're going to do this remotely. And they're good folks. It's not that they don't know their business. They're not that they can't be helpful. They're not that they are not trying to be valuable, but you just need to understand how the compensation works. I have a lot of respect for the Positive Aging Sourcebook. A lot of the information that I had provided with you today, I get out of the Sourcebook, and they have dedicated pages in each of the sections of a checklist of what you should think about, ask about, look at for assisted living, for memory care, for a nursing home. So they have a very useful guide to help focus you on what you need to think about in terms of what are the key criteria and factors when I make a decision. They also have the Sourcebook has all of the possible options, all of the retirement communities, all of the nursing homes, all of the Medicaid waiver facilities, all of the assisted living facilities. So you get a total package of who does what where and for how much, both online or in print. And as I also said, Frank has a very good resource on his website. Iona has a very good resource on their website. Iona has a printed resource guide. Montgomery County has a printed resource guide. You can get other printed and web-based resource documents that can help you with information.
And Jennifer, let me just add that here in the Cleveland Woodley Park Village office at 3601 Connecticut Avenue, we have copies of the Iona resource guide, both in English and in Spanish, as well as the resource book that Steve Gurney produces, the Positive Aging Resources book, as well as many other brochures for many of the facilities that are listed here. So we're open from 10 to 4 every day for people to come by. It's in the Broadmoor apartment building or condo building. And I'm sorry, it's a co-op building, but that's at 3601 Connecticut Avenue. And we'd be happy to share our resources with you. They are printed if you prefer that to going online.
You've been very kind and patient and gracious to sit through 90 minutes today, and some of you sat through 90 minutes last week. Frank and I would very much appreciate any feedback. We're not thin-skinned. There were things that, you didn't appreciate or you felt we didn't do adequate job on, let us know, give us feedback, help us next time around we go around this merry-go-round. It's very difficult with 50 people who have all different needs and interests and backgrounds and expertise to cover the waterfront. But we tried to make this program, the last week's webinar, and this week's webinar as broad as possible to cover as much of the information as we could to be helpful for you and bring you information that is useful to your work and your future and your journey and your personal circumstances. So we thank you very, very much.
Great. Thank you, Jennifer. And thank you, everyone, for attending. Again, last week's session is already up on our website. If you go to cwpv.org/blog, you'll see that presentation there. And sometime tomorrow, early afternoon, we should have this presentation up on our website, cwpv.org. So you can go there, scroll down, and find the presentation. You can also go to our resources section for more of the specific things that we talked about, facilities and care managers and resource guides. They're all there under the resources. Again, next year, we will be presenting a number of these educational sessions. Again, we're going to be focusing on in-home care next. How do you know when you need it? How do you access it? Do you hire them individually or do you hire an agency? Who are the agencies that are available, and what are the things that you need to know, such as, are there a minimum number of hours? Do you get the same caregiver each time? How long do you have to sign up for? These are some of the questions that I know many people have. And so we want to be answering those questions for you. We won't be rating any individual home health care providers, but we will be providing you with some information about things to consider. And I'm hoping that we will have some people that have actually hired home health agencies join us so that they can share their experiences. Again, not about specific agencies, but about how to go about hiring those agencies or employing those agencies versus independent caregivers. So that's our next hot topic, if you will. As I mentioned, we're also open to your ideas about what information you need in order to make informed decisions. So please don't be shy. You can email us at info@cwpv.org, or you can email me personally at frank@cwpv.org, and we will look at all of the feedback that comes in and try our best to offer these educational sessions periodically on topics of interest. Again, I want to thank you all for being here, and I especially want to thank Jennifer for providing such wonderful objective information, which helps us all to make the best decisions about our future. Thanks so much, and I look forward to seeing all of you next time.
You go. I know, but before I cut you off, the chat lit up a little bit more. Is there any last questions, and then we'll close this seminar?
I think people were mostly saying thank you, and appreciate it. So we love that feedback. And again, thank you, Jennifer, and we will be with you in the next educational series in the new year. You can always check out our website. The calendar of events is there. And you can sign up to receive our weekly email on our website as well. And then you can join us for any of the sessions that we offer. Thanks so much, everyone. Have a great rest of the week.
Thank you very much. Thank you all.
Thank you.
Thank you.
Yeah.
Thank you.